Good morning, everybody. We'll go ahead and get started. Thank you all for joining us. It's so nice to see some of you in person who I haven't gotten to see for a few years. So welcome, welcome. So just as a quick welcome, my name is Laura Klesse. I'm a pediatric neuro-oncologist at UT Southwestern here in Dallas, Children's Health, and I'm lucky to be joined by Klesse Romo.
Hi, I'm Klesse Romo. I'm a neuro-oncologist at Johns Hopkins, and I take care of adult patients with NF mostly.
I just want to mention a couple of quick housekeeping things. So we want to say thank you to PeerView for providing this session, and this is funded by an educational grant from Alexion Pharmaceuticals. If you haven't already, will you please do the pre-survey? And just so you know, we're going to have a couple of polling questions through here as well. We actually won't stop to go over the results of that poll because Carlos and I have a lot we feel like we want to talk about today, but if you'll do those for us, that'll give us a good sense of where we are. And if you have any questions, please submit them. We're happy to take them in person, but also please submit them online. You'll be able to see the slides afterwards, and PeerView has put together some practice aids that you'll be able to download, and this is all in your group that you'll be able to access. So a couple of things we really want to try to do today. I just want to review NF1 to begin with, right? It's been a difficult couple years as we've changed names and we've adjusted the diagnostic criteria. So we'll just go through some of that and then really talk much more in depth about how do you develop treatment plans with some of these targeted agents, how do you then decide who qualifies and who doesn't, and then really try to spotlight, we know all medicines have toxicities, how do we then monitor and deal with those? So I'm just going to start with a very quick background. So over the past couple years, there has been some diagnostic criteria changes and some naming differences. So all NF is now referred to as the neurofibromatosis, and this really breaks down into NF1, which you can see up here, and then the schwannomatoses. And these are distinguished basically by what gene is resulting in this neurocutaneous disorder. And so the schwannomatoses are NF2 related if there's a genetic pathologic variant in the NF2 gene, or LZTR, SMARTB1, or 22q related. And then there are clearly some schwannomatoses that we can identify the gene. Those are now known as schwannomatosis NOS. All of these are genetic tumor predisposition syndromes that put patients at the risk for the development of both benign and malignant tumors. And as we all know, there's no cure and there are very limited therapies for NF. And my poor fellows hear this all the time, but I do think it's incredibly important, especially for us as hematologists, oncologists, that we have to be able to identify NF. And there are several reasons for that. There's been very significant progress over the last several years in understanding the biology of NF, which has really opened up some therapeutic avenues that we didn't have before. There are consensus guidelines for screening as well as kind of what to do with some of the complications. And then it's particularly in the setting of NF1, whether or not and how we treat patients with tumors really does depend on whether or not NF1 is present. So just the quick numbers, and some of these numbers actually have changed pretty recently. So NF type 1 now is thought to be about 1 in 2,500 individuals. It means it affects over 120 Americans and 2 million people worldwide. So it means a fair number, 120 patients are diagnosed daily. This is equal across genders with a very worldwide distribution, and this makes it the most common tumor predisposition syndrome worldwide. And I think we forget, particularly in pediatrics, Dr. Romo not so much, but there is clearly a true malignancy risk that goes with NF1. That risk is somewhere between 2 and 10-fold the general population, and means by age 50, you have a 20 to almost 40% chance of developing a malignancy. The genetics of NF1, about half are newly diagnosed, half have a family history, and this is inherited in an autosomal dominant pattern, but it does have complete penetrance. And I mean that a patient who has a pathologic variant in NF1 will have clinical signs of NF1. It's not skipping generations. What's made it quite difficult is that clinical variation is very wide even within families. So about half of patients will have a pretty mild course, but then a very significant percentage will have one that's much more difficult. So the diagnostic criteria was adjusted in 2021, and I've outlined it here. So a lot of it was very similar to before. Cafe au lait macules, you had to have 6 or more, axillary or inguinal freckling, having either 1 plexiform or 2 cutaneous neurofibromas, the presence of an optic pathway glioma, 2 or more Lisch nodules, or as we bolded here, now the presence of choroid abnormalities, having some distinct bone lesions, and then added to this new criteria was having a pathologic variant in the NF1 gene. Now, I do want to point out that variant is not sufficient for diagnosis. You have to have at least a second finding. And then a child of a parent who has NF1 only needs 1 of these criteria. So 2 or more of them all. About 70% of patients can be diagnosed even by age 1 and over 95% by age 8. Uh-oh. Sorry, it's being slow. So then when do you test? I feel like this comes up quite a lot in pediatrics. The majority of patients can be diagnosed by age 10 by the clinical criteria. Where is there a role for testing? You know, the testing in my lifetime has become incredibly accurate, but there are a number of variants within the NF gene. Remember, this is a huge gene, and not all of them are known to be truly pathogenic. So there have been a number of them identified. If you've tested 7,000 plus patients, you've identified more than 3,000 germline variants. And the testing now is very accurate. The problem with it is just like we talked about, there are some known genotype-phenotype correlations in NF1, but not a ton. And so it's not really predictive by and large for families. And it can still be quite expensive. So I think the times where we really say it's helpful is somebody who's an unusual case, somebody who's young who may not meet that clinical criteria, but where you may need to do some therapy decisions. If you're more than 10 without a clear diagnosis, then it's quite helpful. And then there are some associated syndromes, and families you're suspicious of that may be quite helpful for families. Why does NF1 lead to tumors and all the other variants that we see? It's because it really acts as a negative regulator of the RAS signaling cascade in all neural crest-derived cells. So you get a growth signal from the outside that hits that receptor tyrosine kinase, activates this growth signaling pathway, and then NF1 basically is there to turn RAS signaling off. So NF1 is a classic tumor suppressor. If you're born with NF1, you have 1 pathologic variant, so you have half as much NF1 to turn this signaling off. And then basically you kick out the other copy, so you have loss of heterozygosity, and that leads to tumor formation. One of the fascinating things about NF, though, is there are clear time windows where you're really susceptible to the manifestations of NF. There's clearly some overlap, but in this review by David Gutman's group, you can see as you look at somebody over the course of their lifetime, right, the bone findings, plexiform neurofibromas, cafe au lait macules, those are all younger childhood. Same is true with optic pathway gliomas, whereas Dr. Romo's group much more has to deal with some of the true high-grade malignancies. So there's clearly a role for kind of the microenvironment and time windows where people are really susceptible to this loss of heterozygosity and then tumor formation. Okay, I'm going to do a super quick, hey, everybody remember what the kind of clinical manifestations of NF are. So by far the most common are these cafe au lait macules, which you can see in the pictures here below. Often the very first sign, often before age 1, and are present in close to 90% of individuals with NF1. And the skin fold freckling, so axillary and inguinal freckling, which you can see in this top picture, often develops by about age 5 to 7 and is in 3/4 of patients with NF1. The ocular manifestations, these 2 are asymptomatic, but are very good for helping with diagnosis, even in young children. So Lisch nodules are the ones we all know about, these benign hamartomas seen with slit lamps in the iris of the eye, no effect on vision. And added to the clinical criteria are these choroid abnormalities. Require some spectral OCT to really be seen, but are actually found in very high prevalence, probably even more than Lisch nodules. And then the dermal neurofibromas, so these cutaneous and subcutaneous benign tumors that appear to increase in size and number during puberty and potentially pregnancy, although that's not always true. These are benign proliferations of the Schwann cells, but they can be disfiguring and can be quite morbid for patients with pain and itching. They really don't seem to carry a malignancy risk, and surgical removal often can be quite useful. So now is one of those times for you to take your poll, and then I'm going to move on to just a couple of other kind of quick updates on where we are in terms of kind of looking at some of these tumors, and then Dr. Romo and I'll go through much more kind of when do you decide to treat. So a lot of this we're going to focus on plexiform neurofibromas, incredibly common in patients with NF1. So probably at least 50% of patients with NF1 will have these benign large masses associated with a group or plexus of nerves, composed of Schwann cells, fibroblasts, mast cells that invade that help drive its proliferation, and you get this positive feedback growth loop. They are highly infiltrative, can be quite disfiguring, and can be life-threatening. If you see my poor patient up here, all of this is plexiform neurofibroma with a pretty significant scoliosis curve as well. They can be visible on the skin, but they also can be deep, nodular, and not as visible. And we really think these are congenital, meaning you get that second hit early, and they grow over time. The second most common tumor that we see in patients with NF are CNS tumors. So about 20 to 30% of patients with NF1 will develop a glioma. Most of these are benign or low-grade gliomas. They are most commonly found either in the optic apparatus or in the brainstem. So these pictures up here show you an optic chiasm glioma, a brainstem glioma, and then one within the orbital tract. They tend to be slow, benign, but there is a clear risk of high-grade glioma development in patients with NF1, particularly in adulthood. Surgical resection for low-grade gliomas would be curative, but brainstem and optic apparatus are not places where surgical resection is really feasible. And patients with NF1 clearly are at higher risk than the general population, but they tend to do better overall. And really, our field has shifted where we're treating less and less of these. One reason for that is, just like I mentioned before, there is a clear window of opportunity for the development of particularly the optic gliomas. So in this nice retrospective review by Mike Fisher's group at CHOP, they looked at the age where patients were diagnosed with an optic glioma. And you can see the vast majority of patients were diagnosed prior to the age of 10. Less than half of patients now we think require therapy. That peak age is really probably ages 2 to 4. They're much less common after age 8, and really quite rare prior to age 1 and less and rare in adulthood. Part of the reason our shift has come about treating these is MRI findings, response by MRI, and visual outcomes do not correlate at all. And so progression on MRI does not necessarily correlate with vision loss, nor does improvement with chemotherapy on MRI. And they clearly behave differently. So Peter DeBlanc's group put together really kind of a nice treatment decision paradigm for when you decide you need to treat. And I'm not going to spend a lot of time on this, but I do want to point out that it's very clear, I think, in the group, we feel like visual acuity changes or visual field loss, particularly in a young child, is a clear indication that these need to be treated. But after that, it's a little bit harder, and I think you really do have to take into account, are you getting a good eye exam? Even if there's progression on MRI, that doesn't necessarily mean that these need treatment. There are several non-tumor associated findings in someone with NF1. They tend to be macrocephalic. That is not associated with tumor developmental or learning differences. Seizure disorder is more common, up to about 7% of patients with NF1. They are at risk for cardiovascular abnormalities, hypertension, early cardiac death for reasons we still don't quite understand. They are clearly at risk for vasculopathies, so renal artery stenosis, moya, and some cerebral vasculopathy, including vessel stenosis, so something definitely to watch for, and several endocrine abnormalities, short stature, precocious puberty. And then I think one of the most difficult to treat are these bone abnormalities. So bowing of the long bone, pseudoarthrosis, a break in those long bones that then doesn't heal. And then about 30% of patients will have scoliosis as well. And then for all of you who take care of patients with NF, clearly what affects them significantly in their life are some of the neurocognitive and social dysfunction. So this is easily half of patients with NF1. IQ being low is actually a smaller percentage, but they probably don't have IQ span as would the general population. They have very clear difficulty with executive functioning, have difficulty with some of this attention, working memory, being able to follow multiple tasks, very high rate of attention and hyperactivity disorders. And if you look at kids with NF1 overall, about 70% of them are what we consider underachieving. There's also quite a high rate of some social dysfunction. So kids with NF1 are more likely to be socially isolated, teased. We did some bullying work. So much less likely to be well-liked by their peers. And up to a third will have some aspect of autism spectrum disorder. So clearly will meet some of that criteria. So really impacts their day-to-day outcome. And then we've kind of mentioned this, but there is clear risk of malignancy with NF1. So we all think about malignant peripheral nerve sheath tumors, which is probably about 10% of patients with NF1. But there are other malignancies, particularly in the adults, where we really do need to think. And that includes high-grade gliomas, pheochromocytomas, early breast cancer. And in our pediatric groups, JMMLs and rhabdomyosarcomas. So how do we screen them? So there was an updated pediatrics review about how to screen patients with NF1. Consensus clearly agrees on annual physicals, annual histories, including height, weight, blood pressure. Optic glioma assessments are annual by the ophthalmologist at least until 8, and then probably every other year. MRI evaluations are clearly indicated for changes, precocious puberty, new seizure, but their role of screening, as we all know, is still pretty controversial just because of the shift away from being able to use MRI at progression as a clear indication for treatment. And then for plexiform neurofibromas, and I will say this has clearly changed in my lifetime. We used to say physical examination and we'd really look for signs and symptoms of progression. But now, given the potential therapies, we MRI much more consistently, and I think that has shifted over time. And then, particularly in pediatrics, careful assessment of development and neurocognitive and some formalized neurocognitive assessments are really helpful. So now we're going to switch to really talk more about plexiform neurofibromas and their kind of biology and how to treat. So just to give you a quick overview, and then I'm going to turn this over to Dr. Romo, plexiforms, right, we said probably 50% of patients with NF1, we feel like they're congenital. You may not recognize them initially in infancy, but they clearly grow most in young childhood. And so this graph over here shows you the change volumetrically in a plexiform graphed against the age of the patient. And you can see by far the most dramatic growth is in young childhood. And the graph below are individual plexiform neurofibromas looking at tumor size changes over time. You can see once you get to about age 20, the majority of them don't change. It's really more in young childhood that happens. Now, plexiforms can be quite frustrating, right? Two-dimensional MRI doesn't show that volumetric change. Most of us don't have volumetrics readily accessible at our institution, and they can go through long periods of stability. And we'll talk a bit about this, but conventional chemotherapy, which makes us all sad as oncologists, has really not been successful. And radiation therapy really does not have a clear benefit and really puts patients at risk in this tumor predisposition for disorder to true malignancies with almost a 3-fold higher rate. You can get serious complications from plexiform neurofibromas. They are benign tumors, but they clearly can cause both local and neuropathic pain. They can impair function, whether that's compression or infiltration of the nerve, clearly can cause disfigurement, and can be life-threatening if you have mechanical compression of the trachea, large blood vessels, spinal cord, and they carry a very clear risk of malignant degeneration. So how do you treat them? Well, I'm old enough to recognize that we don't need to treat them all, right? For years, we didn't have a therapy, and so we tended to watch the vast majority. But the decision to treat now, I think, really depends on where it is, what symptoms you have, whether or not you do think there's a potential for morbidity or mortality, and whether or not that tumor is growing or has some atypical features. So we're going to spend the next couple of minutes talking about some cases and kind of ways or indications to treat. So before we move on, here's your second polling question. Please answer that on some of the complications we see with plexiform neurofibromas. And then I'm going to turn this over to Dr. Romo.
Thank you. So we're going to start with a case and then hopefully answer some of the great questions that you're already submitting. And I think Dr. Klesse already answered some of those questions, but we'll go back and answer more if we haven't made a good job of answering them during our talk. But let's talk about Andrew, who is 8 years old and has NF1. He has been previously followed due to his NF and a known plexiform neurofibroma in his neck, for which he already required surgery 3 years ago. He presented to our clinic with worsening respiratory distress while he was sleeping. This was affecting his energy during the daytime. He was staying asleep during school days and things like that, and was admitted to the hospital for further evaluation. While he was in the hospital, he had an MRI done that showed significant plexiform neurofibroma on both sides of the neck, as you can see here, with nodules all over. And he also had some degree of scoliosis in the upper thoracic spine that is not well shown in this MR, but trust me, there's something there. And he had signs of a prior Chiari malformation repair. When we look back at his prior images, we saw that the dominant nodule within that big plexiform neurofibroma had demonstrated persistent growth over time and was probably the culprit of why he was struggling with his breathing. A PET CT was done, and there was only minimal uptake in the plexiform neurofibroma, but we saw that it resulted in significant airway compression. Okay, so we wanted to make this a little bit of a conversation as well, and this MRI actually shows that thoracic scoliosis better, which, as you can see, is really significant. Laura, what do you think about this case?
So I think I would sure talk, so clearly all this plexiform is not surgically resectable. But boy, even with minimal uptake, these are a little worrisome and growing and clearly would cause airway compromise. I sure would push my surgeons, I think, to at least try to resect those if they felt it was feasible.
Yeah, and so in our practice, we sometimes obtain MRIs with diffusion-weighted sequences, which can also help in determining that cancerous transformation. We probably would have ordered that as well. A PET CT can be helpful, but we tend not to do that if the tumor has already been biopsied or had surgery directly in the area of concern, because the PET can be alterated just because of the surgery and mislead us into thinking that this is a malignant tumor. But as you were saying, clearly this kid is symptomatic and there's a mass that's growing, so probably we need to do something about this. So surgery for plexiform neurofibromas is still the standard of care. We know that the smaller they are, if they are completely resected, and if they're in certain areas of the body, they have a better outcome. If they're not nodular, if they're diffuse, if they're large, if they're in the face, the neck, or certain other structures like the mediastinum, then it's going to be much harder for the surgeons to obtain a gross total resection. However, partial resections can still help. There are, of course, complications associated with surgery, and this paper by Safi et al. Cited a 32% rate of complications, and you see the list of all the potential problems depending on, again, where the tumors are located, whether they're close to the central nervous system or not, brings a different level of complication. There is also the potential for progression after surgery, even after gross total resection, but of course that's much more common if residual tumor was left behind, which is often the case. A good portion of these tumors, as we were seeing in this particular kid, are not amenable for gross total resection, and depending on who you read, anywhere from 20 to almost 50% of the cases will have some degree of recurrence of those tumors. So the effect of age, younger kids actually tend to do worse than older children. If I was mentioning there are certain areas of the body where the resections are a little bit more beneficial and have better outcomes, those include the extremities. If we go to the trunk, spine, and viscera, that's a little bit worse. And as I mentioned, head, neck, and face, plexiform neurofibromas are slightly harder to remove and of course carry a higher risk of recurrence. And of course, if you just biopsy the tumor, that will increase your risk of them growing even more as if you were to do a gross total resection. So the team thought that surgical resection was going to be beneficial because he was having struggles with sleeping and his breathing. So the nodule was resected, but of course, as you were mentioning, Laura, they couldn't resect the entire plexiform neurofibroma. He tolerated surgery well, and he was able to wear CPAP for night to help with his sleep apnea problems that he was having. So a follow-up MRI showed slow progression, but no dominant nodules causing symptoms. So what are the next steps? Do we need additional surgery? Do we start chemotherapy, traditional cytotoxic chemotherapy? Do we refer him for radiation therapy? Do we start a targeted treatment? And if so, what are our options? Any thoughts about that, Laura?
So I always ask my surgeons. I feel like you always have to ask them up front. I can tell you my surgeons would be like, no more. But I always feel like it's at least worth the conversation. But I feel like in somebody who's clearly having progression, it's not surgically resectable. I think we have to go to more targeted therapy.
Yeah, especially because it seems like this kid is still having some problems and requiring CPAP. It's not like the surgery made him symptom-free. Okay, so what are our options? There have been several studies looking to target the MAP kinase pathway, and you see a bunch of agents here that have been tried in actual clinical studies with different degrees of success. The only one that is FDA approved is selumetinib, which is a MEK1, MEK2 inhibitor, but there are other options that have been tried in different groups, and by different groups, I should say. For example, trametinib, which is another MEK inhibitor, was evaluated in pediatric patients with refractory tumors, and we know that there are several studies. Some of them were looking at plexiform neurofibromas, which is what I'm going to focus on. Some were looking at optic pathway gliomas and other low-grade gliomas. But for plexiform neurofibromas, there are 6 studies published that showed some degree of benefit from trametinib. Some of them, although, are small case series, but the largest one was a phase 1/2A trial in kids that were aged 1 month to 18 years with medically significant, meaning causing symptoms, typically progressive tumors that were unresectable. The final results of this have not been published, but at ASCO in 2018, there was an abstract that gave an interim analysis of 26 patients, of which 46% achieved a partial response. Like with most MEK inhibitors, paronychia and a rash were the most common adverse effects, and one patient did not really tolerate the treatment and was discontinued. So more to come about trametinib, but another option for kids or adults. We also use it very frequently in adults with NF. Mirdametinib is another MEK inhibitor, and it was also studied in a group of patients, in this case 19 patients, ages 16 or older, with a median age of 32. Mostly they were symptomatic, so 90% of them had problems with pain or neurologic dysfunction or compression of other structures rather than tumor growth. And I say that because as we see below, the rate of tumor stabilization or even shrinkage is lower than selumetinib, for example, at 42%. So only 8 out of those 19 patients achieved some shrinkage, but it's important to note that not all of them were growing to start with. They were just causing symptoms. Stable disease was achieved in 53% of patients, and only 1 patient met the criteria for disease progression, as you can see in that waterfall plot there. The most common side effects were also acneiform rash, fatigue, and GI symptoms, including nausea and vomiting. Binimetinib is another MEK inhibitor. It is currently ongoing in a trial that's a phase 2 open-label multi-center study, so the final reports are not available yet, but some data has been reported on Stratum 2, which are kids age 1 through 17. It's still active but not recruiting. It reported 19 patients that were actually evaluable, and out of those, the median age was 12. 74% of them met the criteria for partial response. However, a good portion of them required dose reductions because of side effects. And then selumetinib is the last MEK inhibitor in this list, and it, as I mentioned before, has been approved by the FDA in 2020, specifically for the use in kids aged 2 and older with plexiform neurofibromas. The phase 2 study, the SPRINT trial, was conducted in kids that were having either progressive or symptomatic and inoperable tumors. And the primary endpoint was evaluation of tumor shrinkage by volumetric analysis using MRI. As you can see in this Kaplan-Meier curve, the kids on selumetinib did much better than the natural history control group, where their tumors either shrank or became stable. 68% of the kids achieved a partial response, which was defined as shrinkage of 20% or more of the tumors, again, by volumetric analysis. In addition to that, which I think is critically important to mention, is that not only did they see that the tumors decreased in size, but that the patients actually derived clinical benefit from that. And if you can see at the two graphs, the graph next to the Kaplan-Meier, you can see that on the global impression of change score, they asked patients themselves and their parents how they thought their symptoms were doing other than pain. And the majority of them, 86% of the adults, or the parents I should say, mentioned that they at least had minimal improvement, but most of them had much improved symptoms or very much improved symptoms. And the kids were similar at 72% reporting clinical benefit with the use of selumetinib. Again, the skin rash, the GI symptoms come back with the MEK inhibitor class. Vomiting, diarrhea, nausea for GI, rash, and paronychia are the more common skin findings. We typically start in our practice, although not always the case, and not everyone does this, but we typically start prophylactic treatment for the skin rash. Is that something you do, Laura, as well?
I don't in my young kids. I do in my teenagers.
Teenagers, yeah. So that includes either an oral antibiotic, such as doxycycline, creams, lotions, shampoo, things like that to help with the skin rash and prevent it from getting bad from the get-go. Increased CK levels is very, very common, and as long as they're asymptomatic and not causing renal problems on lab analysis, we typically just monitor them. But if they become symptomatic or cause renal problems, then we start either dose reducing or holding the drug for a while. Okay, so 2020, approved by the FDA in kids over 2, easy to get. This is the recommended dose, 25 milligrams per meter squared twice daily, typically on an empty stomach is preferred. There's a dose reduction for kids with hepatic impairment. Selumetinib is now being also studied in an adult population with the same characteristics as with the kids. That's people with NF1 and plexiform neurofibromas that are inoperable and symptomatic or progressive. And they also saw very similar with the preliminary results. These are not the final results, but the preliminary results have shown that most people, about 69% of them, achieved at least partial response, stable disease in 8 of those reported patients. There were no progressive disease, and a couple of the ones that were reported in this interim analysis were non-evaluable. It is also important to note, because I think there's a question here about the duration of treatment, that a lot of these kids or adults in this particular study did not have their maximum benefit within the first few cycles. Some of them had to wait for 10 to 12 cycles before they achieved their best benefit. So if you can tolerate the side effects, it's worth continuing the treatment until then to get additional tumor shrinkage. Moving away from the MEK inhibitors into a much more dirty drug, cabozantinib, we think in particular Axtel and maybe MER, TK are the ones that we're targeting in plexiform neurofibromas. But in this study, in patients aged 16 or older with NF1, and again, the same criteria, plexiform neurofibromas that were symptomatic or progressive, cabozantinib was used on a daily basis, not BID as with selumetinib. And they saw that a good portion of the patients had some partial response. In this case, 8 patients, which is equivalent to 42%. 11 of the other ones had stable disease, and none actually meet the criteria for progression, which would be 20% or more increase in the size of their tumor. So as we were talking about before, not everyone needs to be treated. I recently saw a patient who came to us for a second opinion, and she had been started on a MEK inhibitor because her tumor was growing on an MRI without causing any symptoms or any problems, but there was a concern of growth. I think sometimes we do that in people where we see that there are those paraspinal neurofibromas creeping into the spinal canal and there's impending neurologic damage to happen. If we see that there's a clear progression towards that and the patient is not eligible for surgical resection, maybe that's when I would consider starting a MEK inhibitor or one of the other drugs, even if they're asymptomatic. However, you have to be thoughtful about that 10 to 12 month lag. So if the tumors are already compressing the spinal cord and causing symptoms, I would probably not use a MEK inhibitor or one of the other class of drugs, but refer them to neurosurgery for resection of that tumor. Pain is another indication. And like I said before, in the adult population, most of the tumors that were studied for Cabo actually were not growing, but were symptomatic. So symptoms are definitely an indication for starting targeted therapy. Anything to add, Laura?
No, I think that's very true. I mean, I have conversations, I'm sure you do too, with families all the time who are anxious. My rule of thumb is you have to have one thing, basically, that your plexiform is causing to lead me to really want to treat it, whether that's pain or morbidity of some kind.
I agree. Yeah, absolutely. Okay. So following up with Andrew, he was started on a MEK inhibitor after the resection that we spoke about, and we counseled the patient and the caregiver about the dosing, the safety, and expectations. Kids that are started on MEK inhibitors have to have baseline monitoring with eye exams, echocardiogram, EKG, and lab tests to make sure that it's safe for them to start the drug, and then they're closely monitored in our clinics once they've started treatment for all the potential complications that can occur. And 1 year after starting treatment, he was able to stop using the CPAP at night, so his symptoms clearly improved, and his plexiform neurofibroma has remained radiographically stable with volumetric assessment. So he continues on treatment 3 years later with this medication. And I think one of the questions that's very interesting here that someone submitted is, how long do we actually treat these patients? Because patients will ask us, is it a 3-month thing or a 12-month thing? How long are we looking into treatment?
And I think it's a very good question. So you mentioned sometimes it takes 8 to 10 months to see an effect. I ask families when they agree to do a MEK inhibitor, unless there are toxicities, to give me a year of therapy to see if we get benefit. And then I have the discussion at 2 years, because everybody reads the SPRINT trial, right? And they came off drug. But I'm very anxious about stopping particularly young kids who had morbidity. And I think this graph shows you very clearly why. So here's where solumetinib was started in this patient. They had to hold it because of a cardiac toxicity and clearly had regrowth. And in my young kids in particular, I see clear growth if we stop at 2. So I have been trying. I do have some families who feel like the burden of coming back and forth is too hard, and so we will trial off. But most families I have asked to try to stay on. And I think with the new published data about long-term use, I actually have more to be able to tell families that that's reasonable. So just published was a 5-year additional follow-up. They continued to see kind of durable partial response in 70% of patients with shrinkage and improvement in symptoms, and there were no new safety signals in this longer-term follow-up. So I really have asked patients. Now, I think yours may be different depending, because I'm in much more of a growth phase. What do you guys do?
We do the same. I think it's interesting, and this is an example, but there have been several cases of this pattern where the tumor not only grows, but grows back to the same pattern of growth that it had before. And then once you start treatment, whether it's selumetinib or something else, they tend to decrease in size again to the same rate of decrease that they had. So it's interesting that the tumors are really starved when we use the MEK inhibitors or Cabo, for example. So we usually stay on it as long as it's tolerated. And patients can take it. One thing that we did not address is, do we know if MEK inhibition or Cabo are preventing cancer?
No, and I think that's a real question, right? So the NICE consensus guidelines said very clearly we don't know if it's preventative, and actually there are case reports of patients developing malignancy on a MEK inhibitor. Clearly not as effective for some of these atypical lesions. So I do not tell families I think that this is a way to avoid malignancy. I think it is very specific in this setting.
And the other question might be, well, if we know that there's malignancy because a biopsy was done, is there any indication for these drugs in the setting of MPNST, which we also, I don't think we addressed?
No, and we will talk about that a little bit more. As a single agent, I think the answer is no. There have been a couple trials who have looked at that. In combination, there may be, but as a single agent, I think the answer is clearly no.
I completely agree. Okay.
Yeah, so I think here kind of our takeaway points for plexiforms are there are therapies, right? Something we didn't have before, whether that's MEK inhibitors or some of these multi-tyrosine kinase inhibitors that clearly have benefit, can result in shrinkage of the plexiform and clear improvement in function. They do not make plexiforms resolve, and I think this is hard, we all know, for families to come to grips with that it's going to get better, but it's not necessarily going to go away. And the effects seem to be only really while you're taking drug, particularly in young childhood. And so I do think you have to get families into the mindset of a long time. And at the moment, solumetinib is the only one that's FDA approved. But all the other drugs we really talked about are in the setting of clinical trials or off-label use.
Great. And there's another question for you to answer in your iPad, and if you can help us with that, that'd be great. And we're going to continue to talk about actual MPNST management. So those plexiform neurofibromas have turned malignant. So we spoke about a case of this is a new case of a 3-year-old with an enlarged left lower extremity that they noted areas of hyperpigmentation in the leg, as well as more than 10 cafe-au-lait macules and a known family history of NF1. Had initial imaging and followed closely by his orthopedic surgeon. And over the following 5 years, she had slow increase in the length of discrepancy and decreased ability to bend both her knee and hip. So MRI remained overall stable to slightly worse. So does this plexiform require therapy or not? There hasn't been much of a radiographic progression, but there is some loss of functionality here. No significant pain, but clearly impacting her daily activities. And surgical resection was not meant to be feasible due to the large extent of this plexiform neurofibroma that was affecting a good portion of her leg. So family opted to go on a clinical trial, but after 2 cycles on medication, decided to withdraw due to side effects. Required proximal tibial and fibular surgery to fix the leg discrepancy, and we thought we should start MEK inhibition at age 13, which improved her orthopedic function and continued on drug for 3 years. However, at age 17, she presented to the clinic with new pain in her right posterior leg and a new mass that she was able to palpate. She noted to have significant changes in the texture of her skin over the mass, but there weren't any significant changes on her exam. So we got an MRI, and we saw that within that diffuse plexiform neurofibroma, there was now what we call a distinct nodular lesion right in this area here. So she had a PET scan, and the PET scan did show some avidity, as was shown here again, which was definitely concerning, so a biopsy was recommended. And before moving forward with the discussion about the surgical approaches, I wanted to ask, when should we get a biopsy in plexiforms?
I think it's a good question, and this comes up at the case conferences pretty frequently because that's terrifying, right? That lesion is texture change, new pain, and really PET avid. It probably needs to come out regardless. I think part of often why we will biopsy is some of these atypicals don't require maybe the same surgical resection that a true sarcoma does. And this one was felt that it would probably likely lead to a neurological deficit. And so I think for both the family and the surgeon to know whether or not they needed to be that aggressive, a biopsy is totally reasonable. But I sure would be anxious to leave it in regardless. I don't know. What do you think?
I totally agree. I think there is a role for biopsying this plexiform neurofibromas, even if there's not a lot of pet avidity. If we are concerned that they're not quite MPNST, but potentially an atypical neurofibroma, or this new entity called an atypical neurofibromatous neoplasm of undetermined biologic potential, or ANABUB, that they probably should come out because those are on their way to becoming MPNST. We don't know when that's going to happen, and once it happens, we could find it too late where there's already metastases. So even if it's one of those pre-malignant tumors, I agree with you. I probably ask our colleagues in neurosurgery and orthopedic surgery or some oncologic surgeon to take care of this as quickly as possible. So of course, if you do a biopsy, there's always different potential responses. One is that, or results. One is that it could be still a benign plexiform neurofibroma, in which case I would still feel anxious about that tumor because of the symptoms, the growth, and the way it looked on imaging. It could be an atypical PN or the ANABUB that I just mentioned. But if it's a low-grade MPNST or a high-grade MPNST, that changes things, especially if it's a high-grade MPNST. And as we were discussing before, the reason for obtaining the biopsy is to confirm the diagnosis so that it can inform the surgical approach. You don't want to do an overly aggressive surgery that will lead to loss of function for a pre-malignant tumor. Whereas if you've confirmed that this is an MPNST, surgeons will probably want to get some white margins to avoid or improve overall survival. And we know that the neurofibromas, we've discussed this before, result as a loss of the second NF1 allele as a second hit, and there are potential other driver mutations, some of which are listed here, with CDKN2A, TP53, and SUS12 being probably the more common ones we see, although ATRX is showing up as a very high frequent mutation that we also see. Surgery continues to be, as with plexiform neurofibromas in MPNST, the cornerstone of treatment, and however, most cases, as with the plexiform benign tumors, they are in many cases not completely resected. So an area, for example, where I would not necessarily recommend a biopsy because it wouldn't change too much the surgery would be, for example, in a kid with mass in the chest in the mediastinum, where there's no way they could get margins because otherwise there'd be nicking the heart, the blood vessels, and things like that. So maybe in that case, if I'm concerned, I would just ask for the safest resection possible. Despite the curative intent of surgery, overall survival remains poor, with only about 50 to 66% of kids surviving past 5 years. And though kids have a better outcome than adults as well, we see that it happens at any age. So for radiation therapy, we had mentioned that in plexiform neurofibromas benign tumors, there's really not a well-defined role of radiation. In MPNST, there is a more established role for radiation, especially in tumors that are not gross totally resected, and especially in tumors that are 5 centimeters in size or larger. Those are common doses that are used for radiation therapy. We already spoke about a little bit of chemotherapy not being very effective with limited role, but it's still used, and various combinations of those medications, including vincristine, cyclophosphamide, ifosfamide, doxorubicin, and dactomycin, have been used in different combinations. One of the studies that we cite the most when we're treating our patients is SARC-006, which was a phase 2 trial using sporadic and NF1-associated chemotherapy-naive MPNSTs. And the patients with NF received 4 cycles of neoadjuvant therapy. Their response was evaluated using a PET and an MR to look for metastatic disease. And if there wasn't any metastatic disease, they usually underwent local control with surgery, followed by radiation. The order of how you do this really does not seem to be very significantly affect the outcome. So sometimes we will radiate patients before surgery, but typically surgeons prefer to have an intact field and only do post-op radiation. Following the surgery, patients recover, and then they continue with typically an additional 4 cycles following IA-IE combination. So most of the NF cases had some shrinkage after 4 cycles as well. We saw the similar results in the sporadic cases. However, in many cases, especially in recurrence, we recommend trying a clinical trial, and there are a few clinical trials that are out there that are available for adults and children with NF and sporadic MPNSTs as well. One of them is the use of selumetinib, and we spoke about this not as monotherapy, but in combination with other chemotherapy agents. This is one of them, SARC 031. There's another one at our institution where we're trying to use nivolumab and ipilimumab as neoadjuvant treatments prior to any resection in kids, and then that's followed by standard therapy. So we started with ipi-nivo, and then we followed typically the SARC 006 protocol, surgery, radiation, and additional cycles of chemo if tolerated. This is currently recruiting patients, so there's no reports right now of efficacy yet, but stay tuned, and hopefully we'll have some good outcomes. And with that, we'd like to finish our official talk, but open the floor for questions. And there are people on Zoom, and so if you have any questions, we're happy to take them, but we would just ask that you raise your hand and get a microphone. Maybe we can get started with some of the questions that we've already received.
So one question I thought was great, in the setting of the first case with the patient who had the neck, where we did a PET CT scan, one of the questions was, do you get PETs up front before you start a therapy? I do not in pediatrics. I'm actually quite worried about the radiation dose with a PET CT. I only do if there's something worrisome. So that patient had a rapidly growing nodule with new airway compression, so I was anxious about that. Do you guys do anything different?
No, I agree with you. In our institution, we mostly use MRI rather than PET, and most of those MRIs include, as I mentioned before, diffusion-weighted sequences, and we look at ADC values to see if there's any signs of concerns. If there's restricted diffusion, we get more concerned, and we typically move from there to biopsy, although in some cases we do order PET scans as well.
And do you guys use contrast? We do not.
It's not necessary, and I think more and more we're leaning towards not using contrast. For clinical practice, we typically do use contrast in most cases. However, we're currently doing a natural history study of distinct nodular lesions, and we're not using contrast in that whole body MRI.
Okay, perfect. One of the other questions was on MEK inhibition. How often do you get MRIs in the absence of new symptoms or visible growth? Every 3 months forever? I do not. Now, I have lots of little kids on it who, I mean, God love them, cannot lay still even for a non-contrasted MRI. So I routinely do every 6 months for the first year, and then I'll often go to a year, just in terms, now I have families who want it more frequently, but I'm not doing it every 3 months.
Yeah, we're not either. I think the reason for getting them a little bit more frequently were, for example, if I was treating a paraspinal tumor that was already causing some degree of cord compression, maybe I'd want to keep a closer eye on that tumor, but otherwise I agree anywhere from 3 to 6 months would be good.
And then the next question was frequency of monitoring in our practice for AEs, labs, echoes, ophthalmology for those who are on long-term MEK. Once you've been on for over a year, I do every 6 months. And I've found routinely that helps with my compliance with families. And so I'm not doing more frequent. After the first year I'm still doing every 3.
Yeah, I think that's the FDA label recommendation, so I think we stick with that as well. With echocardiograms every 3 months, we get ophthalmologic examinations every 6 months, and labs, depending on where they are, as I said before, CPK elevation is very common. Sometimes we have to look at them a little bit more closely, but if they're doing pretty well, maybe once a month.
Good, perfect, okay. And then the next question is how you give selumetinib to patients who cannot swallow capsules. Oh my God, this is like the bane of my existence, and I've already harshed Alexion about it again, poor people. It's hard, and I think I am lucky I'm at a big institution with Child Life who pills swallowed teaches out the wazoo, but it's hard, and there's not another way. I will say, Off-label, we do use a fair amount of trametinib in Texas because there is a compassionate use program. That actually has just ended, though. And so I think it's going to be harder to get the little kids treatment, unfortunately.
Yeah.
Until there's a sprinkle formulation, which hopefully is coming.
I usually don't have that problem with adults.
You don't have to teach?
No.
So. Yes, please.
Hi, thanks for that excellent talk. I've been using selumetinib on my patients, and the problem I've struggled with, which is a little unusual, is hyperphosphatemia. I had an 18-year-old with really big tumors in the mediastinum. They had resected it so much that the neurosurgeons finally sent him to me. And once I start selumetinib, his phosphate goes through the roof. I give him Foslo, I give him, nothing brings it down unless I stop the drug. Reduce the dose, give it once a day. We had to take him off the drug. I have another patient now I still have the same problem with. From time to time, they develop hyperphosphatemia. I have to stop the drug. So because of the hold, even though she's been on it for over a year, she's now having some progression. So I tried to talk to the drug company, and they were like, that's a little unusual. So I was wondering, in your experience, have you had problems with hyperphosphatemia, and how do you deal with it?
I have not. Do
I
you
haven't
see
either.
it?
Haven't either. We check for it, but
So it's a great question because I have not seen it either. And so I haven't had to deal with it. And 2 dose reductions, you still have it? Oh, that's miserable. Yeah, I do not have a good answer for you because I have not seen it.
have you tried a different MEK inhibitor?
What would you recommend?
Probably one of the one we more commonly use is trametinib, but mirdametinib is another option. You said he's 18. Yes. So they would be able to, even if they were younger, trametinib, yeah.
Thank you.
Or Cabo.
Another question on here is length of therapy for solumetinib in optic gliomas. A little different than plexiforms in my experience. I have done 2 years and have not seen the progression for the majority of patients. It's a much smaller minority, and then I have put that smaller minority back on if need be. I think some of that may be that window of opportunity, right, where they're likely to grow and then settle out as they get a little bit older, unlike the plexiforms, which I think are more likely to continue growing. And so I have been able to stop most of my patients at 2 years. You probably do use it less for that.
Yeah, I don't typically see kids or adults with optic pathway gliomas that are causing symptoms. There's another good question here. When lesion is found on a scan on an asymptomatic patient, how do you approach scanning interval once they are referred to you?
Oh my God, this is the bane of my existence. I've run the NF clinic here for like 15, 20 years, and still people in my institution do screening MRIs. It kills me. I tend to do what we do in neuro-oncology. I do 3 months twice, 6 months twice, and then go to once a year. I don't know what you guys do.
Yeah, so it depends. I think if the patient is seeing some progression of their tumor, even if it's not causing symptoms, I would probably scan them a little bit more frequently. If the patient tells you it's been there and it's been like that for 6 years, I may not even scan them again unless there's some progression because they can feel the tumor growing or there's some symptoms.
Agreed. I think that's very true. If it's been there for a while.
And I think that was a composite question about also what do you do? The question disappeared, but do you scan the brain just to scan it in kids?
I do not. I'm a true believer in not doing screening MRIs, but this is what I run into even at my own institution where people screen quite a lot. So I do follow a fair number of optic gliomas that I never treat. But I do not. We have followed the recommendations of ophthalmology, and then for any clinical symptom, do MRIs from there.
Yeah, we see a lot of the FOSSI, the focal areas of signal abnormalities or intensities, or the UBOs, and we also don't follow them necessarily, but we do neurologic exams periodically, at least once a year, to make sure that there's nothing there.
Perfect. I think there was a question about long-term therapy. What's our experience and duration of therapy? I think, as we mentioned, if it's a young patient on a plexiform, I try to keep them on as long as the family will tolerate. And so I have had some patients on for 5, 7 years at this point. And I think now with the publication of the long-term data, there's actually clear safety data to be able to do that.
Yeah. How do you address skeletal manifestations of NF?
So skeletal, obviously, a fair amount in pediatrics we see. We do not do screening, x-rays, or MRIs. We do physical exam. And then we routinely screen for vitamin D and calcium deficiencies. I'm lucky I'm next door to a Scottish Rite hospital for the tibial dysplasia and bowing. But we've really tried to kind of let kids live and then kind of monitor from there. So there is, I will put a plug in, there is a big move because bone is so understudied in NF to really try to understand more what we can do, because adults clearly have lower bone mineral densities, kids are probably more at risk for fracture. There's a clear bone phenotype that we don't quite understand the biology. So there will be a big natural history study, hopefully opening in the next year or two, to really try to get at what is the true bone phenotype, how often does it impact life, and then what can we do from there.
Great. And I think that's our time. We thank you very much for your attention, for being here or participating virtually. Please complete and submit your post-test and your evaluation to obtain credit. And yes, Dr. Klesse said before, you can download the slides and the practice aids as well. And you can watch the video in the next 24 hours and online activity in the next coming weeks. Thank you very much.
Yeah, thanks, everybody.